In today's class, we're going to look at a significant question. Can women with a history of substance misuse breastfeed? We're going to look at general considerations that help you decide if a woman should breastfeed or not. And then we're going to talk about each of the individual substances. Hello, I'm Dr. Ira Chasnoff. Welcome to my class on Nourishing Connections, breastfeeding by the woman with a history of substance misuse. In today's class, we'll be talking about breastfeeding by women who are at high risk for substance use and misuse. The important point is that any substance a woman takes will cross over into the breast milk. This, in fact, is one of the most frequently asked questions when it comes to caring for women with substance misuse. But let's be very clear, we want women to breastfeed. Breastfeeding improves infant nutrition. There are lower rates of infection, allergies, and other complications in the child. And breastfeeding enhances maternal-infant attachment. This becomes important when we consider the impact of substance use and various substances on that neuroendocrine system. Attachment is driven by the dopamine system and oxytocin. So let's talk about oxytocin. Oxytocin is the cuddle hormone. It's what makes us feel good about being with other people. It drives relationships. Oxytocin is produced in the hypothalamus of the brain. An adult woman with good oxytocin systems becomes pregnant. Around 4 or 5 months, she feels her fetus kick for the first time. Oxytocin surges in her hypothalamus. Oxytocin crosses the placenta very readily and hits the fetus. And the fetus says, whoa, that feels good. I think I'll kick again. So this interaction between mother and fetus begins early in pregnancy. Oxytocin crossing the placenta also stimulates the infant's development of a good oxytocin system in the hypothalamus. So by the time the baby is born, he has good attachment strategies. Now, of course, there are environmental factors that come to play as the child grows older, but essentially grows into an adult with good attachment strategies. Oxytocin is flowing. Oxytocin helps that individual fall in love, and life goes on. The problem is that we now know that the chronic administration of drugs of abuse, such as cocaine, opiates, alcohol, substantially reduces oxytocin levels in the hypothalamus. So let's look at that attachment cycle in the presence of substance use. The adult woman is misusing various substances, and there, of course, then are decreased levels of oxytocin in her hypothalamus. She becomes pregnant. 4 to 5 months, the fetus kicks, but she has very little oxytocin response. The fetus has little oxytocin reinforcing his behaviors, and so thinks, well, that was a dud, and stops kicking. So that very early relationship between the mother and the unborn child is disrupted by low oxytocin levels. The infant is then born, has poor attachment strategies, environmental factors come into play, but grows up into an adult with very poor adult attachment strategies. So you can see how substance use during pregnancy can disrupt the very basic human activity of relationships. In addition to these factors, there also is a sense of enhanced maternal empowerment and higher levels of self-esteem when women can breastfeed. And, of course, a positive relationship with her infant promotes the woman's recovery. So yes, we want women with a history of substance misuse to breastfeed. However, we have to understand that any substances a woman takes will cross over into the breast milk. Why? Because substances of abuse, in order to cross the blood-brain barrier, must have two characteristics. They must be lipid soluble, which means they absorb into fat very readily, and the brain is, of course, all fat, and they must be of low molecular weight. These two characteristics mean that any substances the woman takes will cross readily into her brain, but also means cross readily across the breast milk and the placenta. So our challenge now is to understand each of the individual drugs, and so we're going to look at them considering how rapidly each of these substances transfer into breast milk, the impact of secondhand smoke, if applicable, the effect on the breast milk supply, the effect on the infant in the immediate, as well as long-term, and then most importantly, what advice do we give to the woman who is using substances? So let's start with nicotine. Nicotine transfers very readily into the breast milk. Nicotine is completely absorbed from the lungs, moves into the mother's bloodstream, and then crosses over into breast milk. It will persist, nicotine levels will persist for about 2 hours in the breast milk. Now, importantly, when we're talking about smoking cigarettes, of course, we have to consider secondhand smoke. Through passive smoking, the infant absorbs all the products of cigarette smoke. Nicotine levels in the baby's blood are greater from passive smoking than from taking in nicotine only through breast milk. But the effects add together. When a woman is smoking cigarettes, nicotine reduces the volume of her breast milk. Now, direct effect of cigarette smoking on the infant: nicotine flavors the milk and can limit the baby's appetite. Babies often show fussiness at the breast and sometimes refuse to nurse if the woman has just recently had a cigarette. Nicotine ingestion can cause the baby to vomit, have diarrhea, be restless, and have a high heart rate. There is an increase in colic in infants of mothers who smoke 5 or more cigarettes per day. Now, we're talking mainly about smoking cigarettes, but be aware that vaping nicotine will produce all these same effects, although you do avoid the effects of secondhand smoke. So what is our advice to the pregnant woman who's smoking? Quit smoking. That is the only way to protect the infant from the effects of cigarette smoking. Now, a nicotine patch with about 14 milligrams per day of nicotine or less will decrease the nicotine levels in the breast milk, compared to smoking about 1.5 packs of cigarettes each day. And this would be a good place to start when trying to help the woman quit smoking while breastfeeding. Now, if the new mother continues to smoke cigarettes, advise her to wait to smoke until after she has breastfed the baby. She should never smoke and breastfeed at the same time. Smoke outside and then wash up and change clothes before she picks up the baby. And be aware that even these 2 steps will not completely protect the baby from the effects of secondhand smoke. Let's turn our attention to alcohol. Again, alcohol crosses very readily into the breast milk. Levels of alcohol in the breast milk are just about the same as levels in the mother's blood. Also, alcohol flavors the breast milk and changes the smell of the breast milk, so the infant may refuse to breastfeed. Now, alcohol reduces the volume of breast milk by about 23% after only 1 standard drink of alcohol. And contrary to popular opinion, drinking beer or any other form of alcohol does not increase the number of calories in the breast milk. You must understand that infants through 3 months of age break down alcohol very slowly, about half of the rate of adults. So 1 drink per day or binge drinking 5 drinks or more once per week has been associated with delayed psychomotor development in some studies. However, not all studies have found this. One standard drink results in the infant sucking harder, but getting less milk and becoming mildly sedated. In the 4.5 hours following ingestion of alcohol through the breast milk, infants have been found to be more wakeful. Now, one study published in 2016 was an evaluation of a population-based breastfeeding sample. Mothers who breastfed and drank alcohol, their children had significant reductions in weight and verbal IQ. Through logistic regression, it was found that breastfeeding and drinking significantly compromises child development. So, what do we do if a mother calls and says, "I'm breastfeeding, but it's New Year's Eve. I want to have some drinks"? What do we tell her? Well, women should avoid alcohol use at all for at least the first 3 months of the infant's life. If the baby is older than 3 months, then she should eat before and while drinking. Food will help absorb the alcohol. At the same time, she should drink plenty of non-alcoholic beverages when drinking alcohol. And then she should avoid breastfeeding for at least 3 to 4 hours after her last drink. She should pump and discard all breast milk during that 3 to 4 hour period. Another good step to take is to store alcohol-free breast milk for use after moderate or heavy drinking. One of the most frequently asked questions now is, what about marijuana? Marijuana is highly lipid soluble. Thus, it is quickly absorbed into the breast milk, and you can find THC levels, the active ingredient in marijuana. You can find THC levels in the fat content of breast milk for up to 2 weeks after the last intake of marijuana by the mother. Chronic heavy use of marijuana results in higher levels of THC in the breast milk than in the mother's blood. We also have to consider the effects of secondhand marijuana smoke. Just like nicotine, babies will absorb significant amounts of marijuana smoke, including THC, if they are exposed to someone smoking marijuana. Once again, marijuana does decrease the supply of breast milk and has some short-term significant effects on the infant, in that the infant who has ingested marijuana through the breast milk will show lethargy, will look weak, and will feed very poorly. Animal studies have shown changes in the structure of the brains of newborn animals exposed to marijuana through their mother's milk. There is one human study that shows that marijuana exposure via breast milk during the first month after delivery had some negative effect on the infant's motor development at 1 year of age. But very few studies have done, and the evidence is fairly unclear about the long-term effect on marijuana ingestion via breast milk on the infant's development. So what advice do we give to the woman who's smoking marijuana? Given this lack of extensive research, the best thing is to completely abstain from marijuana use when breastfeeding. If the woman is going to use, then she should follow the same advice that we gave for cigarette smoking. If the mother smokes marijuana only occasionally, she should store some unaffected milk. And because judgment can be hampered through marijuana use, the woman should be sure to have another caregiver who's not using marijuana available to take care of the baby. Unfortunately, we do have to consider the effects of the illicit drugs on women who are breastfeeding. I think the best way to look at this is through a study we published several years ago. This was a 26-year-old mother who used, quote, large amounts, end quote, of cocaine in the first 2 months of pregnancy. She binged on alcohol, about a half-fifth of hard liquor 2 to 4 times per month in the first trimester, then 2 to 3 beers per week through pregnancy. She delivered an infant who was reported to look perfectly normal. The infant was 38 weeks gestation with appropriate growth. By 2 weeks of age, the infant was being exclusively breastfed. When the infant was 1 week old, the mother put a dab of cocaine on her gums, breastfed the infant, and saw that nothing happened. At 2 weeks of age, the mother and her husband were invited to a Christmas party. At the Christmas party, the woman ingested about a half gram of cocaine over a period of 4 hours. They then went home, and about 3 hours after the last ingestion of cocaine, the baby started getting irritable, was vomiting, and having significant diarrhea. His pupils were dilated, and the infant was unable to focus. The parents brought him to the emergency room, where I had a chance to evaluate the infant, and in fact, he was poorly responsive, very irritable, continued to have vomiting and diarrhea. And yes, it was noted that his pupils were dilated, and he was unable to respond to any kind of stimuli. Now, we did not know at the time about the mother's history of cocaine use, but began taking a more thorough history, and that's when we found out about the cocaine. And so we hospitalized the baby, and the mother stayed in the hospital with the infant and allowed us to collect her breast milk. You can see that the infant's levels of benzoylecgonine, the primary metabolite of cocaine, so the concentrations of benzoylecgonine in the infant's urine were over 800 nanograms per milliliter in the urine. Until about 30 hours of age, there were detectable levels of benzoylecgonine. This leveled off, and by 60 hours, there was no detectable benzoylecgonine in the infant's urine. Now, more importantly, let's look at the breast milk. 10 hours after the last ingestion of cocaine, the breast milk had 400 nanograms per milliliter of benzoylecgonine in the breast milk, which slowly began to fall until there were no cocaine metabolites left by about 40 hours after last ingestion. So these are significant levels of cocaine and metabolites in the breast milk after almost 2 days after last ingestion of cocaine. Now, this information for cocaine can also be applied to methamphetamine and opiates. So what do we see with these drugs? Significant amounts will transfer into the breast milk. The amounts in the breast milk and the length of time they stay in the breast milk will vary with the frequency and the amount of drug use. It has been noted that methamphetamine can stay in the breast milk up to 100 hours after use. Cocaine, as we showed, stays in the breast milk about 36 to 60 hours, and heroin and other opiates, including prescription opiates, can be found in the breast milk for about 24 hours after last use. So what effects do we see on the infant? Heroin is not absorbed very well by the baby, but exposure through the breast milk can cause sleepiness, breathing problems, vomiting, and irritability in the infant. If the mother has used cocaine, the baby can become very irritable and have seizures or other neurological problems after breastfeeding. There are no formal studies on methamphetamine's effects on the breastfed infant, but there are some case reports of seizures and infant death within a short time after being breastfed by a mother who has used methamphetamine. And always, as we talk about breastfeeding by women who are using substances, especially the illegal substances, we have to remember the risk of HIV/AIDS and hepatitis C. Obviously, we have to consider methadone. For the woman who is receiving medication-assisted treatment, we do want her to breastfeed. But be aware that methadone does cross over into the breast milk. It peaks in the mother's blood about 1/2 to 1 hour after an oral dose and lasts up to 60 hours in the mother's bloodstream. Obviously, the higher the mother's dose of methadone, the more that is present in the breast milk. Most studies show that methadone levels in the breast milk are so low that it is a safe medication to use when breastfeeding. There is very little information about buprenorphine and breastfeeding, But methadone in the breast milk can help a baby if he is having withdrawal from opiate exposure during the pregnancy. If you have a mother who's on methadone maintenance and is breastfeeding, you have to observe the infant very closely for sedation, respiratory depression, and neonatal abstinence syndrome. Our advice to the mother who is on methadone maintenance: if she's in a treatment program, encourage breastfeeding. Try to time the daily dose of methadone so that she takes it just before the baby takes his longest sleep of the day. The woman should be cautioned not to suddenly stop breastfeeding, but try to taper the baby off the breast. This helps to slowly reduce the methadone dose the baby is getting through the breast milk and will obviate any withdrawal as the baby comes down off the dose of methadone. So what are some general guidelines we can use when we're considering breastfeeding by women with a history of substance misuse or abuse? Here are the guidelines that we use in our own clinical program. The woman has to have a negative history and negative urine toxicologies throughout the third trimester. In addition, the woman should have a negative urine toxicology at the time of delivery. This at least gives us some indication that she is not actively using. The mother must be HIV negative. There is a question as to whether a woman who is hepatitis C positive can breastfeed. In fact, the American Academy of Pediatrics says that it's okay for a hepatitis C positive woman to breastfeed. However, in my own clinical work, I advise women who are hepatitis C positive not to breastfeed. My concern is that due to the cracking of nipples and the bleeding of the nipples during breastfeeding, which almost always happens, hepatitis C could be passed through the mother's blood to the baby via breastfeeding. Methadone at any dose is probably fine, but again, clinically, I prefer the woman to be on less than 40 milligrams per day. And of course, the woman must be monitored and must have ongoing negative urine toxicologies while breastfeeding. First of all, if a woman has had no prenatal care, I would be very reluctant to have her breastfeeding. Substance abuse or misuse in the 30 days prior to delivery or refusing substance abuse treatment are both negative indicators, and the woman should not be breastfeeding. If the woman is unwilling to consent to communication between her medical personnel and the substance abuse counselor, or if there are positive maternal or infant urine toxicologies at the time of delivery, or if there's postpartum relapse at any level, and if the mother is HIV positive. These are all contraindications to the woman's breastfeeding her new infant. Again, let me emphasize a few important points. Methadone at any dose is probably fine. However, again, I do prefer if the woman is on less than 40 milligrams a day. A woman on methadone maintenance should not stop breastfeeding suddenly, but should taper the breastfeeding schedule. And of course, we want good medical supervision of the infant to ensure that the infant is not being affected by the methadone. Hepatitis C, as I mentioned, is controversial. The American Academy of Pediatrics says it's okay to be hepatitis C positive and breastfeed. I advise against it. And finally, a question that we just don't know much about is psychotropic medications. There is very little information. You can assume that any psychotropic medication the woman is on will cross into the breast milk. Do we allow her to breastfeed? In most cases, yes. But we have to monitor the infant very closely. All of this information is accessible through a very handy table book, Nourishing Connections, which is available through the Sacramento County Department of Health Substance Use Prevention and Treatment Program. The multiple drugs listed under the various tabs in this table book provide all the same information that I provided you through this class. If you need further information, you can go to the Sacramento County Healthy Beginnings website or to our website at ntiupstream.com. Thank you for joining us for this class today. We look forward to any feedback or questions you may have.